Hello everyone, welcome to the webinar. We will just wait a minute for people to join and then we will start with the webinar. Okay, so I guess we can start now. Hello everyone, my name is Camelia and I will be your host today. I'm project manager of work package 6 and today's topic, as you can see, is long-term outcomes in CAIS. I want to thank MTG7 for organizing this webinar and making it possible. Our speakers today are Giovanna Mantovani and Alessandra Mangone. They will introduce themselves in a bit. And I just wanted to say that all questions usually come at the end. You can use the question box in the upper right corner to ask them and they will be answered at the end. So without further ado, I will give the word to Giovanna to introduce herself and Alessandra.
So thank you, Camelia, and good afternoon to everybody. Thank you for joining us for this webinar. The title is Long-Term Outcomes in Complete AIS. And together with Alessandra, we have thought to start this webinar with the presentation of two cases, two quite similar but different cases. We both, just to give a short introduction on ourselves, we both work at Policlinico Hospital in Milano, and we are both adult endocrinologists. Please, Alessandra, you can start with presenting these two cases.
Thank you very much. Can you see the presentation?
Yes, we can see it.
Okay, thank you. I'm gonna start with a couple of very quick clinical cases just to introduce a bit from a practical point of view the topic of today's discussion. The first case, her story started when she was 17 years old and she was sent to the pediatric clinic of her city due to primary amenorrhea. Her previous history was quite unremarkable. She only had a tonsillectomy and atopic eczema, and her puberal growth and puberal development had been normal, with starting around 10 years old. At examination, she presented quite tall with a breast tanner stage 4 and thin and scarce pubic and axillary hair, and the most striking finding in her laboratory exams was the presence of high levels of total testosterone within the male range. At the abdominal ultrasound, which was performed, there was the finding of a lack of uterus and ovaries, and this finding was confirmed at a subsequent pelvic MRI, which confirmed the absence of uterus and ovaries and the presence of a short vagina with a blind ending, which you can see here reported on the right in her MRI, and also the presence of two images compatible with the testes in the inguinal canal. The gynecological examination was also consistent with a female vulva and a vagina with a blind ending, so the diagnosis was already quite clear and was confirmed by the presence of a 46 XY karyotype and most importantly a genetic analysis which confirmed the presence of a mutation in the androgen receptor gene, which upon evaluation also resulted present in the mother, who was a carrier of the same mutation. So we have all the elements, of course, to pose the diagnosis of a complete androgen insensitivity syndrome. which, as you know, is a difference of sex development characterized by an activating mutation in the androgen receptor gene, which is very often, as in this case, transmitted from an asymptomatic mother who is a carrier of the mutation. And depending on the residual activity of the receptor, we can have different phenotypes. When the receptor is completely insensitive to testosterone, we have the complete form, as in this case. It's a very rare disease with a low incidence and prevalence. And very briefly, what happens is that in an individual with a XY karyotype, we have the development of functioning testes, which on the one hand produce the anti-Mullerian hormone, which causes the regression of the Mullerian structures, and therefore the absence of uterus, fallopian tubes, and upper vagina. On the other hand, the complete insensitivity to testosterone doesn't permit the development of the Wolffian structures, and therefore the phenotype is completely female. They have a normal breast development thanks to the aromatization of testosterone into estrogens at a peripheral level, and it is very typical, the presentation with the primary amenorrhea. The testes are retained, usually in the abdomen, or as in this case, in the inguinal canal. Nowadays, the gonadectomy and indication to gonadectomy can be discussed with the patient and the families after completing the puberal development, and in this case, they decided to keep the gonads and maintain a radiological follow-up. Then, as it often happens in these cases, she was a bit lost in the transition from the pediatric to the adult care, and so she moved to another city. She was lost a bit, and then she arrived at our attention when she was 25 years old in 2019. Her laboratory findings were quite normal, quite stable, with absent tumor markers which are performed in the presence of gonads in situ, and the pelvic MRI, fortunately, was comparable to diagnosis, so stable in dimension and characteristics of the retained testes. We also performed a complete bone evaluation through a DEXA scan, which only revealed a slight impairment at the lumbar spine. In these patients, since they are very young, we mostly focus on the Z-score, and quite a normal at femoral sites, and a slightly low level of vitamin D, so she was started with a supplementation with cholecalciferol and an increase in dietary calcium intake, but for the rest, we just maintained a follow-up. So we kept a follow-up through an annual biochemistry and dermal evaluation, which, as you can see, has maintained quite stable, annual tumor markers, which are keeping negative, an annual evaluation, and every 2 years we are repeating a pelvic MRI, which is also keeping stable. Here you can see the first one performed in our center, and then the last one from last year, and the dimension and characteristics of her testes have kept stable. We also repeated the ADEX examination after 3 years, which showed a slight improvement at the lumbar spine and femoral sites which are stable, and so we are keeping her follow-up. As a final note, we also include a psychosexual assessment in this adult patient through by administering some self-administered questionnaires, exploring a bit their sexual function and the presence of sexual distress using these scales, and also the BAT, which is a questionnaire which assesses more the presence of body uneasiness and dissatisfaction with their body. And on the right, you can see the result of this patient who is not reporting any problem in her sexual function, but a slight impairment in her perception of her body. The second case has the same diagnosis, but quite a different story. She was diagnosed, she had a prenatal diagnosis because of a mismatch between the karyotype and the fetal phenotype, and she underwent a prophylactic gonadectomy at birth because of parental decision. She was then induced with estrogens at puberty, and then a hormone replacement therapy was started with a pill with a combination of estradiol and progestin. In 2021, so when she was already 19 years old, she had the communication of diagnosis, and then she was referred to our attention in our clinic. So when she firstly arrived, she was a bit shocked by all the situation, and she had there was a lot to do. First of all, she was referred to a dedicated psychologist for starting the appropriate diagnosis acceptance process and support. A gynecological evaluation was performed with evidence the presence of vaginal hypoplasia, and she was indeed reporting some difficulties in sexual intercourse. So the process of non-surgical self-dilatation was started, and from an endocrinological point of view, we stopped the combination pill, and we started her with an only estrogen or hormonal replacement therapy, since in the absence of uterus, progestin is not necessary. Her laboratory findings were stable, keeping with a gonadectomized patient, and for the rest normal. She brought us a previous DEXA examination performed in another center, which was showing an important impairment at the lumbar spine. So we started right away cholecalciferol and calcium supplementation, but we firstly focused on the psychological support and gynecological process. We also informed her about the Italian Patient Association, AISIA, which is quite active in Italy and supporting if necessary. And we continued to see her. This is the subsequent follow-up when we started to focus a bit more on her evaluation. We repeated a complete evaluation in our center with a complete DEXA scan, which confirmed the presence of an important impairment in bone mineral density, both at the lumbar spine. As you can see, she had a very negative finding of minus 4.2, and also at femoral level. The X-ray morphometry performed as a screening for asymptomatic fractures was negative, and we also performed a complete screening of other causes of osteoporosis, considering the important impairment, which was all negative except for the finding of an excessive loss of calcium in the urines, which was also repeated and confirmed. And so we started her with a small dose of chlortalidone to reduce hypercalciuria, and we also changed her hormonal replacement therapy, modifying the oral formulation with a transdermic patch formulation of estradiols, since there are some evidence that it can have a better impact on the bone. These are the result of the same psychosexual assessment showed before, just to show you that the female sexual distress scale, which is a screening for the presence of sexual distress, as you can see, a score above 11 is considered quite pathological, and she had 38, so an important distress in this issue. And she also reported some body uneasiness. This is her last follow-up of last year, so the DEXA scan was repeated after 2 years, and as you can see, is still impaired, but has showed an important improvement in bone mineral density, so is considering respect to the baseline as quite improved. The X-ray morphometry is still negative for fractures, and so we have confirmed her therapy, and she is ongoing with that. So this was just to show you 2 cases with the same diagnosis, but some different clinical pictures, just to underline how this is a very heterogeneous condition, and management is quite complex and needs to be a bit individualized according to the patient we have in front of us, keeping in mind, of course, the multidisciplinary aim, and so considering also the psychological, the sexual and gynecological aspects, together with our clinical and hormonal evaluation, and also the issue of bone health must be considered, and maybe treatment decision evaluated accordingly, since they are very young patients experiencing these issues. But of all that will now better explain you Giovanna.
So, thank you, Alessandra. Now I will wait for Camelia to give me the possibility to share my screen. That's I cannot do at the moment.
Yeah, I stopped mine, so maybe it can help.
Okay. So can you see my screen now, Alessandra?
Yes, I do.
Okay. So we can start with the second part of this webinar, and as nicely introduced by the cases that Alessandra just showed you, the challenges regarding the long-term management of complete AIS, but in general of many DSD in adulthood, are rather similar, and they are listed here. But if you want to further simplify the picture, the main challenges include the preservation of fertility whenever this is possible, the treatment of hypogonadism and of its complications, and the management of long-term comorbidities, which may be condition-specific, but in most patients include cardiovascular, metabolic, bone, and psychological ones. And currently, very little is known about the long-term outcomes in adults with complete androgen insensitivity syndrome. And we should really need to put together our efforts to produce some evidence-based data and, as a consequence, some kind of recommendations. So for this reason, we tried to gather some information on what is going on in Europe, and particularly within the Endo-ERN centers. So we set up a survey with the aim of collecting data on how women with complete AIS are diagnosed, treated, and followed. And so my talk today will alternate some data from the literature together with the results from the survey and some personal experience here in Milano. The questionnaire was circulated last April and was closed 1 month after, in May. And 24 centers, that is about half of Endo-ERN centers, provided a feedback. And a lot of questions were focused on long-term treatment and outcomes. We collected information on almost 300 women, but most of them were pediatrics, so quite very few adults. And in detail, you see here the disproportion between the pediatric centers, which were the vast majority, 72%, and the adult ones. So I think that the first important information that we can gather is that we are really losing many, many women during the transition period, as Alessandra has already showed you with some practical cases. So these are the main aspects we have to focus on when dealing with adult patients living with AIS. And on this, I will rapidly discuss with you today. So the management of gonads, hormonal replacement therapy, bone health, fertility, vaginal hypoplasia, sexual and psychological function, and metabolism and cardiovascular health. So, on the management of gonads, as Alessandra anticipated, you all know that our attitude has completely changed over the last 20 years or so. And so while before gonads were automatically removed as soon as the diagnosis was achieved because of the risk of gonadal germ cell tumor, now we know that the risk of malignancy is quite low, especially in the first decades of life. And the general approach is to wait until early adulthood in order to allow a complete and spontaneous pubertal development, the final height, and possibly also the peak of bone mass. And by this approach, the decision on if and when to go to surgery should be discussed with the patient, sometimes with the parents as well, but mostly with the patient. And in complete AIS, starting from adolescence and early adulthood, we should start to inform the patient on the pros and cons of gonadectomy, highlighting that on one side, we do not have a standardized non-invasive screening approach, and that the risk of germ cell neoplasia in situ is around 10 to 15%. And on the other side, the risk of malignant transformation seems to be quite low, and that there will be the need of lifelong HRT, but I will come to this issue in a few minutes. In partial AIS, the scenario can be a little bit more complex, as the choice will depend also on gender identity. But this is not the focus of this afternoon's webinar. These are the results on an interesting survey conducted in 2018. And you see that the most common approach is to consider gonadectomy only on indication before puberty. And routinely after puberty. And out of 166 complete AIS women who underwent gonadal removal, a carcinoma in situ was found in 2 cases at surgery. And these are the results of our Endo-ERN survey, where the large majority of experts actually discuss about gonadectomy only after the achievement of the age of maturity, as indicated by the current clinical practice. And as far as gonads are still in place, the most common approach is to monitor on a yearly basis, both by imaging by either ultrasound or MRI and biochemical markers. So HRT, hormone replacement therapy, is a crucial point in these women. And indeed, hypergonadotropic hypogonadism is present in virtually all AIS individuals after gonadectomy. And I would like to add that we should not take for granted that gonads will be perfectly functioning even when left in place. And in all these cases, an undergot HRT is mandatory. HRT should be assured at least until the average the average of natural menopause in these women. And there is no unique HRT protocol or any evidence-based data on the optimal hormone formulation, the routes of administration, the doses, and the monitoring parameters. And adherence to HRT is often not optimal, so we should dedicate time to explain why HRT is important for these women. What kind of formulations and of molecules we should use? The first sentence seems rather obvious, as these women do not have a uterus, but actually it's not that obvious, because unfortunately several women still undergo a combined therapy with estrogen plus progestin, at least in Italy, but not only. Of course, we have plenty of formulations and choices when we speak of estrogen supplementation. In general, we should try to use the more physiological way of supplementation with both oral or transdermal, gel or patch, bioidentical estradiol. These are the preferred formulation. And if the woman accepts it, and this is not always the case, we should prefer transdermal options that allow a better personalization of the doses and guarantees a more physiological delivery. Keep in mind that the optimal dose of HRT in complete AIS is currently unknown, and so we just refer to the dose of estrogens that are usually used for the substitution in non-DST hypogonadic women. So we do not have clear clues for what we should and how we should monitor these women. And also the therapeutical targets are not that clear. So we can learn some lessons from premature ovarian insufficiency, where the aim is for a physiological estradiol levels as found in the serum of women with normal menstrual cycles. So that is 100 to 200 picogram per ml. This is, picomolar per liter. And look at the doses that we should use, usually around 100 microgram if we would use a transdermal estradiol, or 2 to 4 milligram if we use an oral or gel estradiol. And usually we do not achieve to have such estradiol levels in the serum of women from our personal experience. Also keep in mind that to be completely reliable, we should measure estradiol by mass spectrometry, which is rarely done on routine basis in most labs, so this is not possible most often. And estrogen dose should be titrated to achieve symptom control and adequate BMD, so quite rough targets. So this is our cohort in Milano, almost 40 women, adult women, that we are currently following up. And you see that despite standard HRT doses, most patients, almost 70% of women, have estradiol concentration below 50 picogram per ml. And also patients with intact gonads had low estradiol together with high gonadotropin. This is seen in both gonadectomized and non-gonadectomized women. And if we take into account the 5 women with intact gonads, 2 out of 5 also have low testosterone levels. So, can we think about testosterone treatment in these women? The rationale is that many women report a decrease in well-being and sexual functioning after gonadectomy. And this is a well-known German multi-center randomized double-blind trial that explored this issue. So we had 26 women randomized. They were assigned to either estradiol 1.5 milligram per day for 6 months, followed by crossover to testosterone 50 milligram per day for 6 months, and vice versa. And the primary outcome were mental health related quality of life measured by the SF-36 questionnaire, while the secondary outcomes were psychological well-being, sexual function, somatic effects such as signs of virilization, and the effects on metabolic blood values. Well, the results, the 2 treatments were equally well tolerated. No differences were observed, with the exception of testosterone being superior to estrogens in improving sexual desire, but not in the other items related to sexual function. And of course, further data on larger series and with longer follow-up are needed before making statements on this issue. So how are we treating these women in Europe, or at least in Endo-ERN centers? Well, the majority of experts prefer estradiol, either transdermal or oral. But some centers are also prescribing ethinyl estradiol or a combined pill. And only 3 centers are actually offering the possibility to have testosterone if the woman wishes so. And this is also in line with reported literature. For how long? At least until the average age of menopause, but even longer if the woman would prefer so. But overall, the optimal long-term HRT with aging is also an issue that needs to be explored in this setting. So bone health. We know that both estrogen and androgen through their receptors are crucial for maintaining an optimal bone mass and quality. And data from knockout mice demonstrate a significant loss of bone volume and trabeculae with a shift towards bone resorption. And the androgen receptor is indeed expressed by osteoblasts and osteocytes. But why should the bone be affected in AIS and in complete AIS in particular? Gonadectomy indeed represents a major risk factor for bone health due to iatrogenic hypogonadism, but there might be other factors possibly affecting the bone in complete AIS, such as the lack of the androgen receptor itself, but also some behavioral factors and sometimes also an inadequate HRT, either because of lack of compliance or because of inadequate doses. In general, a reduced BMD, especially at the lumbar spine, is reported in women with androgen insensitivity syndrome. Although the data are quite limited and heterogeneous, in particular, for some reports, the genetic analysis is lacking, so that we cannot even be sure that we're talking about AIS. And for partial AIS, the data are even more scarce, being limited to a few case reports. This is a nice publication with a review of the literature by Bertelloni and colleagues on complete AIS with removed gonads. And you see how few patients are included in most papers, but even if we limit the results to those in the largest case series, you appreciate how lumbar spine is especially affected, being mostly in the osteopenic range. Again, this is a well-conducted study on 32 adult patients with complete AIS and 32 healthy controls, age-matched. And BMD was found to be significantly lower in complete AIS in respect to controls. This at all sites, so the lumbar, the femoral, and total body, but again with the lowest values at the lumbar spine. As in previous studies, there are no data on fractures. The data are even more limited, but there seems to be a tendency to lower BMD also in women with intact gonads. And this might be due both to the lack of the receptor itself, but also to the state of partial hypogonadism that we often observe in these cases, with testosterone levels which are usually not that brilliant and gonadotropins that are almost always high. Apparently, there is no association between the age at gonadectomy and BMD, and after gonadectomy, there is no further worsening, but again, very few data. So can we impact on bone health with an optimal HRT? Probably yes, as suggested by this paper, but only if we give high doses and transdermal formulation. But these data, again, are still far to be conclusive. These are the data from our series in Milano, and usually we register an impaired BMD at the lumbar spine in patients with and without intact gonads, and overall almost half of the patients had a pathologically reduced lumbar spine BMD. And in this 47.2%, we had 5 gonadectomized women and 2 women with the gonads. And femoral BMD was less affected, especially in the female with the gonads left in place. No significant difference were found between BMD values and different HRT regimens. And in addition, and this is something new to the literature, we collected systematic information on fractures, and we found a fracture rate of around 8%, which is quite high if we consider the young age of these women. And the fractures were all in women who underwent gonadal removal. Interestingly, also bone turnover markers seem to be higher in this population if we compare it with age-matched controls. But this I want to point out, despite receiving a standard HRT dose, and mostly we're referring an optimal compliance, only 9 patients, that is around 1/3, had a serum estradiol concentration above 50. Interestingly, all patients with intact gonads also had low estradiol concentrations. And this is in accordance with this case report, where a high-dose estrogen up to 3 milligrams per day for 4 years induced an improvement of the BMD. So we should keep an eye on the dose and on the optimal estradiol target levels in these women. Back to the survey, DEXA seems to be performed in most centers, and overall we can retrieve a finding of either osteopenia or osteoporosis in up to 40% of adult patients, which is also similar to what we observed in our case series in Milan. So fertility, there is little to say about this topic in complete AIS, of course, because of course normal androgen receptor is necessary for male reproduction, and patients with androgen insensitivity syndrome are infertile. Despite there are reports on sperm count improvements after high doses of testosterone, at least in partial androgen insensitivity syndrome, while complete forms tested histology reveals incomplete spermatogenesis, increased fibrosis, Leydig cell hyperplasia, and low frequency of spermatogonium. So there are no reported cases of biological fertility. And there is only one case of successful fertility described in a partial LIS individual after a prolonged high-dose testosterone therapy. Vaginal hypoplasia is indeed an issue in some of these women, not all of them, and there are no evidence-based data on which is the best approach for this condition. As you know, there is, and also as Alessandra anticipated, we have a surgical approach and a non-surgical approach with self-dilatation, and nowadays we tend to prefer the second one as a first-line therapy, and this has been also confirmed by the results, by the feedback we received in our survey. So the non-surgical approach seems to be the preferred one in all centers. Sexual and psychological function. Of course, psychological support is essential within a multidisciplinary approach in AIS as in all DSD. And talking about fertility, sexuality, karyotype is indeed delicate, and so, but they are topics that need to be approached with the individuals with androgen sensitivity syndromes and their families. And within the general well-being, let's say, sexuality plays an important role in psychological health, and androgens are believed to play an important role in female sexual function, but yet the evidences are still limited. But overall, a reduced sexual satisfaction is reported in AIS individuals, and in partial androgen insensitivity syndrome, there seems to be a high prevalence of gender dysphoria, and this is not the case for complete AIS. So at our center, as Alessandra already told you, we have investigated sexual well-being by using 3 standardized questionnaires. First of all, the female sexual function index that investigates many items of sexual function, and the female sexual distress scales that investigates the presence of a sexual hypoactive disorders, and BAT that assesses body uneasiness and dissatisfaction. And these are the results, and they indicate that more than 50% of these women have pathological scores at all the 3 tests, with no evident difference between women with or without gonads, and no significant differences among the different HRT regimens. But we can affirm that patients not taking HRT, these are the ones that I'm underlining here, showed the worst pathological results in all questionnaires, while among the small subgroup of patients on testosterone therapy, the results seems to be a little bit better, although not significant. And although not significant, again, we also observed a slight trend between estradiol levels and a better sexual function. Again, not significant. And the survey confirmed that sexual function is not always investigated in clinical practice, and even less with standardized questionnaires. We have very, very few data on metabolism and cardiovascular risk. There are alterations directly induced by the lack of androgen receptor that altogether lead to a possible impairment in insulin sensitivity, alterations in lipid profile and metabolism, and an increase in visceral fat with possible obesity. But to date, there is only one study exploring the cardiometabolic profile in 18 women with complete AIS. And this study confirms a less favorable profile with increased obesity and body fat and an unfavorable lipid profile. But interestingly, fat mass and obesity were higher in women with intact gonads. And I must say that despite the low numbers, we have the same feeling if we think about the women that we are following at our center. But again, to summarize, we need many more data on this topic. This is my last slide. When we asked if European experts would welcome the elaboration of guidelines for this condition, the answer was almost unanimous. And I leave you with some take-home messages. So there are still many underexplored long-term comorbidities for which multicentric longitudinal studies are needed in order to gather information and offer the best interventions. Optimal hormone replacement therapy is probably crucial to prevent many of these comorbidities. Despite this assumption, we do not have standardized and evidence-based schemes on the type of hormone that we should use, the doses, the route of administration, the timing, the things that we should monitor during the HRT, and the need of HRT also in women with intact gonads. And with this, I thank you for your attention, and I thank again Alessandra, but also Eriselda, who together with me take care of women with this condition at our center. Again, thanks for your attention. So, I think that now we should be able to take questions.
Yes, we have two questions at the moment. The first one is, may I ask for cases of CAIS, which gender should we refer to when reporting a BMD Z-score in DXA, female or male?
Oh, this is a very important and very very nice questions. Actually, we don't know. I mean, in general, the system automatically uses women references, which I think it's the correct way. At our center, we tried also to analyze our data using the male reference range, but more or less we got the same results. But usually we use the women reference range.
And the second question that we have received says, thank you speakers for the wonderful talk. What could we offer in a teenager with CAIS who opts for male identity? How long should IM testosterone injection be given? Is there anything we can offer if the teenager who chose the male gender and felt troublesome with the presence of bilateral breasts? Is there anything that can be done to augment the phallus in the teenager choose for the male gender? Thank you.
So this is a tough one. I mean, I guess that the question is more related to partial AIS rather than complete, because in complete AIS we cannot, I mean, we can give testosterone, but we will not achieve a virilization of the patient, because obviously the patient is resistant. So I don't think there are case reports on complete AIS. I hope I'm not wrong, but I guess that the only approach would be surgical. So we do not have the possibility to use androgens in this setting. The things are different in partial androgen insensitivity syndrome, because in this case, obviously, gender identity is the gender is assigned at birth or soon after birth. So in that case, it happens that with adolescents, the adolescent might want to choose to change, and in that case, there are no schemes or protocols, but we should use testosterone at higher doses than are usually used in any other case of virilization induction. So. And in partial insensitivity syndrome, it is quite common, because the literature reports about 25% of gender dysphoria.
Thank you for your answer. We have one more question. 25% of gender dysphoria in PAIS. Which publication is the question?
So I got this. I don't know if I can go back to my presentation, because I don't think I'm sharing the screen now, but I can retrieve the slide, maybe, if I have 1 second to do so. Fertility. So, Alessandra, if you have it before me, you can, but I'm just looking at the slide, because I skipped, I have the slide, but I skipped it before because of time constraints, and also because the webinar was focused on complete AIS. Okay, am I able to share again the slide?
Yes, you can share your screen. And while you're doing that, there is a question for Alessandra that she can answer while Giovanna is trying to share her screen again. So, Alessandra, if you leave the tests in situ set, you follow the patient with tumor marker. What's tumor marker?
Yeah, so we usually measure both LDH, alpha fetoprotein, and HGC as a screening, but of course the diagnostic value is very limited. It's just the easy way to assess together with the hormonal and biochemical evaluation, but it's very important to maintain, of course, the radiological surveillance as well. So it's just an additional tool which we, as well as the literature, suggest to add.
So I don't know if you can see the slide now. So this is the meta-analysis from which the 25% was retrieved. So if you want to look at the single reports, you should read the the meta-analysis.
We can't
Okay,
see
so
the.
I'm sorry. Sorry?
We cannot see the slides.
Oh, okay.
Yes, now we can see.
Okay, you can see it now?
Yes.
Yes.
Okay, this is the meta-analysis I was talking about. Just for reference, then you can go and see the single papers. Okay.
Thank you.
I should quit.
There are other questions. One is, what is the best imaging technique screening test for tumor development in adults?
So I can answer as I told. There is not a standard. Also from the survey, some experts use ultrasound, some experts use MRI. We usually use MRI, and depending on what we find, we decide case by case on the timing of the next one. So usually maybe one every 2 years. But again, it's just related to some good sense and not to guidelines or to solid evidence-based data.
Thank you. And the last question that there is, in your experience, how high the dose of testosterone should be given in PAIS? Up to 250 milligrams testosterone enanthate.
First of all, we must say that we do not have experience with these schemes, not personally at least. If you look at the literature, the high doses are considered 250 milligram testosterone enanthate weekly. So 4 times what was considered the standard therapy, substitutive therapy in males, in hypogonadic males.
Thank you. There is one more question that just came in. If you want to keep tests in situ until peak bone mass is achieved, what age do you recommend to remove the testes?
Well, peak bone mass is usually achieved around 20, 25 years of age. So we usually wait at least until 20 years of age. But then again, of course, we start speaking of this topic well before the 20 year. The woman is 20 years, but we usually advise to wait for this decision after this age.
Thank you very much, both of you. If there isn't any more questions, I suppose we can finish this webinar. I don't see any questions, so thank you again, Giovanna and Alessandra.
Thank you.
Thank you.
Thank you also to all the attendants.
Thanks.
That we do not see, but okay.
Hey, thank you. Goodbye. Have a nice evening.
A nice evening to you as well. Bye bye.
Bye.
Ciao.